Good evening, all. Today, I'll be sharing my abstract that is ANASARCA and systemic capillary leak syndrome as an unusual presentation of juvenile dermatomyositis, report of 3 cases and systemic literature review. My mentor is Dr. Narendra Bagri, Additional Professor, Department of Pediatrics, AIIMS, New Delhi. Case 1 is a 3-year-old boy who presented with the complaints of fever and rash for 1 month, progressive muscular weakness for 1 month, fast breathing in ANASARCA for 4 days. There was no history of joint pain, alopecia, photophobia, weight loss, no history of oliguria or hematuria. On examination, vitals were stable with heart rate of 148 and BP in between 58 to 98 centile. The child required oxygen support by nasal prongs. On physical examination, we could see generalized body swelling, ANASARCA. There was heliotrope rash. There was Gottron's papules. There was subcostal retraction. There was hypotonia, and power across all the joints was 2/5. Gag reflex was also absent. Investigation to us revealed there was hemoconcentration, neutrophilic leukocytosis, and thrombocytopenia, along with hypoalbuminemia, hyponatremia. On further investigation, we found that the inflammatory markers were raised along with raised muscle enzymes, including AST, ALT, CK. Immunological workup was negative, infective workup was negative, and urine routine microscopy didn't show any proteinuria. So, considering the heliotrope rash, Gottron's papules, and proximal muscle weakness, diagnosis of JDM was evident. But ANASARCA, hypoalbuminemia, neutrophilic leukocytosis, thrombocytopenia, hemoconcentration, and hyponatremia suggest towards third space loss. So why this third space loss in JDM? So we thought the possibility of JDM with a very rare presentation of systemic capillary leak syndrome. This is the hospital course of that child. Initially, the child was on oxygen by nasal prongs. The child worsened due to proximal muscle weakness, child an episode of aspiration, followed by cardiac arrest and further requiring mechanical ventilation. We had given the child antibiotics. Initially, when we suspected JDM and overlapping SCLS, that is systemic capillary leak syndrome, we started IVIG, then we give IV methylprednisolone and steroids. Even we give the strong immunosuppressant suspecting systemic capillary leak syndrome, we have given IV cyclophosphamide. During the course of the hospital stay, child gradually improved. There was improvement in the WBC counts, in the albumin, in the ferritin levels. And the child was discharged on day 45. Case 2 is an 8-year-old boy who presented with the complaints of fever and facial rash for 1 month, myalgia and difficulty in standing for 1 month. Examination revealed ANASARCA, heliotrope rash, Gottron's papules, proximal muscle weakness, and bilateral pleural effusion. Similar to the previous case, this case also has the similar findings of hemoconcentration, neutrophilic leukocytosis, and thrombocytopenia, along with hypoalbuminemia and raised muscle enzymes and inflammatory markers. So this case also, as previously, was diagnosed with JDM with the findings of third space loss suggesting systemic capillary leak syndrome. This child was diagnosed a bit late and started with the immunosuppressants, but child, as the complication of systemic capillary leak syndrome, child also developed AKI, for which hemodiafiltration was done. And there was this was refractory hyperkalemia, and unfortunately, child succumbed to the illness despite giving immunosuppressants. Now, case 3 is a case of 7-year-old girl. This is a very unique case which presented the complaints of fever for 15 days, bilateral lower limb pain for 15 days, generalized body swelling for 10 days. She was actually referred to AIIMS as a suspected case of nephrotic syndrome. But on our evaluation, we could find the heliotrope rash, Gottron's papules, and proximal muscle weakness with poor gag, suggesting juvenile dermatomyositis with systemic capillary leak syndrome. And the investigation of this girl also showed same thing, that is hemoconcentration, neutrophilic leukocytosis, and thrombocytopenia, along with hypoalbuminemia and hyponatremia. Muscle enzymes including CK, AST, ALT were raised. Inflammatory markers were also raised. In this child, the urine protein was +1. So ruling out nephrotic syndrome. Further, urine creatinine protein to creat ratio was also not in the nephrotic range. So this child was labeled as JDM with systemic capillary leak syndrome. And further, to confirm our diagnosis, we had the child underwent MRI, which classically showed hyperintensities, and nail fold capillaroscopy done also showed typical findings of JDM, that is giant capillary loop and arborization of capillary loop. So confirming a diagnosis of JDM with systemic capillary leak syndrome. This Since we have seen previous two cases, this child was also managed with the immunosuppressant from very starting. We had given antibiotics for fever, we had given immunosuppressants, and we have given IVIG initially, then IV methylprednisolone for 30 mg per kg per day for 3 days, then a course of steroids and IV cyclophosphamide. Over the course of 12 days, we can see a gradual improvement in the counts and the clinical condition of the child. In between, this child also underwent the complication of systemic capillary leak, that is AKI, for which the child underwent hemodiafiltration and child gradually recovered. This, as I told, this is a very rare presentation. So this cases, like 5 cases have been reported in the literature, and 3 we have reported. So the cases have been reported by Menegal et al. In 2017, where they have showed
1 minute left.
Okay, where they have showed 3 children with the similar complaints, and they have managed also with the aggressive immunosuppressant. We have recorded our 3 cases presenting with almost similar complaints, and with the use of aggressive immunosuppressant and timely management, we could save 2 child. So for the discussion, the capillary leak syndrome is a constellation of diseases manifestation associated with increased capillary permeability. Idiopathic primary SCL is believed to be cadherin defect, whereas secondary, that is in JDM, is due to result of uncontrolled inflammatory cytokine storm resulting in endothelial injury. Classical laboratory features are as we have discussed. So what are the treatment options? Treatment option is to control the hyperinflammatory state, and immunosuppression is must. IVIG and pulse methylprednisolone forms the first line therapy. There is no strong evidence of PEX. We speculate that PEX can be useful in tiding over the cytokine storm that is seen in JDM when it is associated with systemic capillary leak syndrome. Hemodiafiltration have been shown effective in removing
Time's
middle
up.
molecules. Thus, what conclusion is कि strong immunosuppressant the key to manage such case, and timely management and identification is important. Thank you.